you'd be taking a bioidentical hormone, but you're not. And there are actually around 7 or 8 different types of estrogen products, some of them extremely, extremely potent, that are in horse-based serums, synthetic serums, which should not be used.
All right, so I'm very excited today to have Dr. Edward Jacobson talk to me about bioidentical hormone replacement therapy and women's health issues, and a lot of the things I hear from my clients and women that I talk to over 40, 50, and beyond. So thank you, Dr. Jacobson, for your time.
Good morning, Linda. How are you?
I'm great, thank you. I want to just read what your credentials, because it's important, and then I'll let you fill in the blanks if I missed anything. But you've been in practice for over 30 years. You're a board certified gynecologist. You're you're accredited by the Bioidentical Hormone Society, the International Hormone Society, the Bioidentical Hormone Initiative, and also the American Academy of Cosmetic Gynecologists. And I also noticed that you are accredited by the worldlinkmedical.com, which is an international certifying agency for expertise in bioidentical hormone replacement therapy. So are you also an OBGYN or just a gynecologist? Did you ever deliver children or no?
I've delivered about 5,000 babies
Okay.
in the past over 25 years. So yes, I stopped my OBGYN practice a couple of years ago and just been a gynecologist, and more recently, just doing hormone replacement therapy for men and women via telemedicine.
Okay. Okay. And yeah, with that, I want to just jump right into a lot of the things I hear. I work with women over 40, 50, and beyond in the midlife space as a nutritionist, helping them with lifestyle modifications through what they're eating, how they're moving, how they're sleeping, lots of
Right.
different things, drinking enough water, all the lifestyle things that everybody needs to do, but for some reason they seem to forget. So it's my job to help remind them. But also, when I get a woman who comes to me and is having a lot of difficulties with her hormonal imbalance, a lot of anxiety, depression, night sweats, hot flashes, what else is there? The list goes on. Weight gain, hair loss, just feeling not like themselves anymore, fatigued. There's so many symptoms that I hear, and I decided I really wanted to look more into that, given that I'm also in that space and I was having a lot of those same symptoms. But some of the things I hear, and I have a whole list of questions, but I want to talk about the myths surrounding bioidentical hormone replacement therapy, that
Yeah.
it causes cancer. If someone has had cancer, they can't do bioidenticals. If they've had breast cancer, they can't do it. I have clients that have asked me about blood clotting and they're susceptible to blood clotting, and their doctor told them they can't do it. What else have I heard? That they have a family history of cancer, they can't do it. Lots of different reasons why. And I know from talking to you a lot, because I'm also a patient of yours, which I think is a disclaimer to also say that I do work with you personally. But it's important to have answers to these questions from someone like yourself who's versed in the area, not just, a general practitioner or some type of doctor that may not have the education in the area that you have.
Okay, so I think a little history is important here. Before 2002, before the Women's Health Initiative, many women were taking hormone replacement therapy, primarily synthetic hormones. You may recognize some of the names: Premarin, Prempro, Provera, excuse me, very successfully in terms of preventing osteoporosis and heart disease, and feeling very well. And then when the Women's Health Initiative came out, is actually a very terrible study, but it caused a lot of fear amongst women and a lot of doctors. And it suggested that there was an increased risk for breast cancer, blood clot formation, and stroke. At that point, and when I was practicing as well, I had my concerns as well. And many of my patients stopped taking hormones. And then within a month or two, they started to complain of the symptoms that you brought up, Linda: flushes, night sweats, sleep disturbance, and the whole, all the problems that are associated with menopause. And at that point, some of us, as practicing physicians, concerned about offering women an alternative. And the alternative was bioidentical hormones. Bioidentical is synonymous with a term called natural hormone formation. And natural hormones come primarily from yam and soy. The body sees it itself, so it has a means of processing these hormones, taking them in, utilizing them, and eliminating them safely, versus the so-called synthetic hormones, which is primarily horse-based estrogens, okay, which have an inflammatory component to it, okay. I think if you're a menopausal mare and you took Premarin, you'd be taking a bioidentical hormone, but you're not. And there are actually around 7 or 8 different types of estrogen products, some of them extremely, extremely potent, that are in horse-based serums, synthetic serums, which should not be used. So at that point, it became obvious that using bioidentical hormones, although there was very little medical studies associated with it to show that they're safe and beneficial, they were starting to be utilized. And over time, more and more of these studies have come through proving safety.
Okay. So now that leads us to the question of when people hear from their doctors that maybe they have cancer in their family, someone along the way maybe had breast cancer or ovarian, cervical, some kind of cancer, that they can't do it. Or if they are, I've talked to women that have, are breast cancer survivors who have said, oh no, my oncologist said that's never going to be an option for me. And I've read a book called Estrogen Matters by Dr. Bloom, which I know you're familiar with. Right. And he does negate a lot of that thought process in his book. And I always suggest women go get that book either on Audible or hard copy and read it, because it's going to help them really understand more about that they might be able to be a candidate for replacement therapy, even if they have had breast cancer. So I wanted you to speak a little bit to that woman. Sure. who's saying that.
So that was a book that came out several years ago, written by Dr. Avra Blooming, who happened to be a medical oncologist, a cancer specialist, whose wife had breast cancer, and she is on hormone replacement therapy. That's a pretty strong validation. And he pretty much takes apart the findings and derivatives of the Women's Health Initiative. So we've sort of come full circle in terms of our studies, randomized controlled trials, proving cause and effect of the benefits of natural hormone replacement therapy. And these are the conclusions that we have in 2024. Number one, having a family history of breast cancer does not mean you cannot take hormone replacement therapy. Even if you have a BRCA gene, you can take hormone replacement therapy. We feel that natural hormone replacement is actually somewhat protective against breast cancer, right? Natural hormone replacement therapy does not cause blood clot formation. Synthetics can in the first year that you use them, but naturals do not. And naturals are not toxic to the liver if taken orally. In fact, there are 2 ways of taking estrogen. There's topical or there's oral. And oral has the benefits of being cardiovascular protective against Alzheimer's disease, and certainly protective against osteoporosis, as is topical. But considering the fact that 90% of women will ultimately die from some cardiovascular event, not a breast cancer event, it behooves women to consider taking oral estrogen. And a lot of doctors are not comfortable with that yet. And so that's really very, very important.
Right, because when they're undergoing therapy for breast cancer, they're taking tamoxifen or raloxifene or those drugs to help stop any kind of estrogen in their system. Is that correct?
Exactly. And by doing that, it actually deprives women of the cardiovascular protection that estrogen affords. And so they're actually a greater risk for from heart disease and stroke, uh, being protected against breast cancer.
Okay. And then what about the woman also too that will say, I have some kind of cancer in my family, whether it's, doesn't have to be a female, a breast or an ovarian or cervical. Maybe her dad had pancreatic cancer or someone
Right.
had some other type. How would you answer that woman?
So here's the feeling: if a woman has had breast cancer and she's been successfully treated and she's cancer free for over 5 years,
Okay.
I have no problem restarting estrogen replacement therapy. If she's had uterine or ovarian cancer, and she's cancer free over a year, then she can restart estrogen replacement therapy. I have about 8 or 9 women who fall into the category of breast cancer survivors who have been doing well for 10 years or longer with hormone replacement therapy. So a lot of oncologists are not comfortable with this. And it's unfortunate that the most liberal oncologists will allow for vaginal estrogen cream, which is really non-absorbable. It's not systemic, but it will allow for decreased sexual discomfort. But that's the extent of it, and many will not even allow that. So it's it's hard to convince people that there's a safety factor here and there's a quality of life factor and a longevity factor that's extremely important when taking estrogen replacement.
Absolutely. And
Mm.
it's interesting too. Some of the other things I hear, there's a lot. I have a whole list here, but I have clients, women that are in their early 60s and have said to me, "Oh, it's my doctor told me it's too late for me. I missed the window, or my hormones are low. That's just the way it is. I'm 60 something years old, so just kind of accept it and move on. It's too late. You can't do hormones now. It's too late." What do you say to that? And how old?
That's
Actually, how old is like your oldest female patient that you have on hormones?
I'd say about 85 or 86
Okay.
right now. That 60-year-old age group comes from the Women's Health Initiative, where it implied that if you've been more than 10 years from menopause or over 60 years of age, you shouldn't be on hormone replacement therapy. There's no study that proves that. The implication is that that woman has had 10 years to build up plaque on her coronary arteries and put herself at risk. And the implication is that by going on estrogen replacement therapy, you're going to put her on greater risk. And I don't think that's ever been proven out, which is why I successfully start women at any age.
Right.
In particular, you have a woman who is in her 70s and has osteopenia and osteoporosis. She's a great risk for fracture, and there's a mortality associated with that. And most of the medications that are on the market only slow down the dissolution of the breakdown of bone. Estrogen uniquely can arrest that and actually reverse it, whether it's topical or oral, depending on the dosing. It's a wonderful medication, and these women should not be denied that ability. And I have many women on estrogen replacement simply for that reason. They get the other benefits as well. They sleep better and so forth, libido. But age is not a limiting factor.
I want to ask you too a question. So my mom will be 80 in March, and it's interesting because she was in that Women's Health Initiative. She was taking Premarin, I remember. And when they yanked everybody off it, I remember her starting to have hot flashes
Right.
and night sweats, and she was uncomfortable. And then she started having a lot of joint issues and arthritis. She does have osteoporosis at 80 years old. She deals with a lot. She always looks great and smiles, but I know she's in pain a lot. You can see her hands are her fingers are a little distorted from the arthritis. And we were chatting about it when I was home at Christmas. And I said to her, well, my first thought is, and one reason of my motivation for wanting to do bioidenticals is I've watched her suffer with osteoporosis pretty much probably from her late 50s, 60s on up to now at almost 80. And I don't want that to happen to me just by
Sure.
watching what's going on with her. I'm like, I don't want that to happen. And But I said to her, you should talk to your doctor about maybe doing some sort of a estrogen patch or an oral or some kind of a little bit of hormone replacement therapy. It might, could she get some benefit at 80, a little bit, or not really, or in your opinion?
It's hard to give a general answer to that
Okay.
question. I'd have no trouble trialing it. I'd
Hmm.
keep it very simple.
Hmm.
I don't think you have to necessarily go oral. You can go topical.
Okay.
Uh, uh, Bioidentical patches are available and are most commonly used by doctors who do prescribe hormone replacement therapy. I don't think at 80 some odd years of age, you're looking for major cardiovascular dementia benefits because
Right.
I don't think the studies show anything that's going to be beneficial. But for osteopenia and osteoporosis, possibly estrogen does have an anti-inflammatory component to it, and she may benefit from it. And quite frankly, the downside is almost nil. And if after a period of observation, several months, half a year, she doesn't receive any benefit, then she can just simply discontinue.
Okay. I was just, it's interesting watching her go through this, and it's a great example of a woman not using, not replacing her hormones as she ages, and then seeing the deterioration. Just, cognitively, she's great. Her heart health seems to be fine, but definitely her bones are a huge issue. And she's had a hip replaced already. She's going to replace a knee soon, but
Right,
but she's great. And I wonder, if I had a crystal ball and I could look back, and if she had stayed on some kind of replacement,
right,
you know what I mean? If she had,
sure.
where, how would she be now? Would she not have a lot of these issues that she's having? So it's, and watching her, I knew that that's not what I want for myself. Like, I want to do all the things that I can to keep my own health there through eating right and exercising and using some replacement therapy. And I think my opinion, and I'll be curious to know what you think, is I don't know why any woman would not do hormone replacement therapy.
I agree entirely. And there's a corollary to that for women who are on hormone replacement. It's, doctor, how long do I stay on this?
Yes.
Now, if you listen to what the FDA says and what they black box on commercially made products, they'll say you should go in the lowest effective dose for the shortest period of time, not to exceed 5 years. So where does that come from?
Right.
Nothing scientific. Okay. And what happens when you do go off? All the symptoms that you've had are gone. All the protection that you've had is gone. Your risk for osteopenia, osteoporosis kicks right back in. It makes no sense. In fact, Medicare sends out notices to physicians to take their patients over 65 off of systemic estrogen, go on an antidepressant if mood is a problem, and a vaginal estrogen cream. I mean, this is almost insanity. Okay. So when people say, how long should I stay on? I say you can stay on to your 110. At that point, you can go off. Because if you do go off beforehand, all the benefits are lost.
Right. And that, in that book, Estrogen Matters, he does reference that. Like, if you stay on, as long as you're on it, you're good. But the minute you go off it, you lose all those
That
protective
is
benefits.
correct. That is correct.
And just the fact that women will ask me that, well, how long are you going to be on these hormones for? And I said, well, probably till I die. Why would I stop? I said, I don't, they're like, well, I don't really want to take medication. I don't want to take medication for forever. And I said, well, I don't look at it as taking medication. I said, I look at it as I'm taking supplements, just like I would continue to take my antioxidants and use the creatine and all the other supplements that I use every day. I'll be
Right.
using those until I die. So I just look at it, this is just an addition to my supplementation regimen. I don't look at it as, oh, now I'm on medication.
Exactly. Exactly. It's how much do you want to have a positive impact on your quality of life as well as your longevity?
Absolutely.
So, which begs the question, why do you take hormone replacement therapy? And there are basically two reasons. One is the obvious for symptom relief, and you outlined all the symptoms that are easily benefited by taking hormone replacement. But then there's the cardiovascular benefits. And there's some absolutely phenomenal studies out there that most people, even my medical colleagues, aren't that familiar with. Probably the most important is the cardiovascular benefit. And that is if one takes oral estrogen, not topical estrogen, and you optimize the use of oral estrogen. I'll explain that in a few minutes.
Okay.
One can reduce the risk of fatal heart attack and stroke by as much as 50%. Now, there's not too much else out there that'll reduce the risk of a heart attack by 50%. And if one starts taking oral estrogen within 2 years of menopause, you can reduce the risk of Alzheimer's disease by 50 to 80%. Mm-hmm. These are major issues, but it has to be taken orally. Okay. It doesn't work if you take it topically. So here's the problem. Most doctors who prescribe estrogen feel very comfortable prescribing it topically, whether it's a cream, a spray, excuse me, a patch, because they believe, truthfully, that there's no blood clot association with that. What they don't understand is that there's no blood clot association with oral bioidentical estrogen. There is one for synthetics, and that's where that comes from. And that's only in the first year of synthetic use. So you get the cardiovascular benefits and the dementia benefits orally, which is why 99% of my patients are on oral estrogen. There are a few reasons not to take it. People who have predisposition to blood clots and so forth, and other medical problems. It's probably wiser to stick with the topical. But for the most part, the oral is definitely the way to go. And that's very, very important. So that's one aspect. Now, I mentioned the term optimization.
Yes.
Right. Optimization is a term that refers to bringing hormone levels back to when they were ideal, when you were 20 to 25 years of age. You can't bring people back to that age group and feel that great, but you'd like to. But if you bring the levels back there, that's where the studies show you get these benefits. Okay. And you don't have that when you take a topical medication. Typically, that's a simple approach, taking a topical estrogen along with progesterone to prevent overstimulation of the lining of the uterus. Right? It doesn't require much monitoring. Patients they feel better, they'll go their way until they see their doctor the next year and renew their prescription. Optimization requires a lot more monitoring because you're bringing levels much higher than what you would get topically. But that's where you get your benefits. In addition, we also add on testosterone, which is extremely important for maintaining and building up muscle mass, reducing inflammatory proteins, backing off risk for heart disease and diabetes. DHEA, which counterbalances the stressful effects of cortisol, optimizing thyroid, and other nutritional components to good health. This is a whole different approach, but the benefits are far greater than just the simple approach. And it's not for everybody. It requires diligence and a desire to do this and to be monitored closely. I have many patients who just take the simple approach, just a patch and a pill, and they're very happy. And I'm delighted they're taking it.
Right.
But it's not what I would consider the ideal approach.
Okay. And you said something too, that a woman who's predisposed to blood clots, can they use the oral bioidentical estrogen, or you would put them more on a patch or a cream at that point?
I think from a safety, just, there's the medical and then there's the social aspects to this. Okay, so if I had somebody who has a genetic predisposition to blood clot, it's a genetic thing, I'd be inclined to put them on a topical. Okay. Because very simply, the family, the doctors are all going to be concerned about this. And I'd like the patient to have at least most of the benefits of estrogen. Okay. If somebody has already had a blood clot, they've had a pulmonary embolus, well, their chances for another one are very, very high. So why put into the mix going on oral estrogen if somebody's concerned, or even any type of estrogen for that matter, most doctors would probably not even consider that somebody's had a pulmonary embolus. So these are a very limited number of people, and you have to look at each person and their situation. Why do they have a blood clot? Do they have it because they have a clotting disorder, or because they're in a motor vehicle accident? There's a big difference.
Okay.
All right, so you have to individualize.
And what about a woman in midlife who's had a hysterectomy, but they've left her ovaries in? And we know that ovaries produce estrogen, progesterone, testosterone. So what happens to that woman? Would she be similar in the sense to someone like me that I have not had a hysterectomy, I still have everything? Would she still be doing a similar protocol if she came into you and said, hey, I've had a hysterectomy, but my ovaries are still in? Would you still go through the same type of protocol you would as if a woman did not have that?
Well, you have to look at that person from two different perspectives. Is she perimenopausal, or is she menopausal? If she's menopausal, her ovaries have primarily ceased function. They're not making estrogen, not making progesterone, a little bit of testosterone, right? So yeah, she would be as if anybody else who would be menopausal. The real issue is if she's perimenopausal, which means she's transitioning. If she had her uterus, she'd be having some bleeding. She may not be having bleeding. She'd be having flushes and night sweats. She'd be feeling good. And we call that no man's land, because she's always making some. And if you're giving her some, what happens? She starts to have symptoms of water retention, bloating, breast tenderness, irregular bleeding. It's a tricky time. There are ways of dealing with that. You don't try to optimize that person. You try to make that person comfortable without having other aggravation. But yes, I think that as a corollary to your question, if a woman's had a hysterectomy, does she need to have progesterone?
That was my next question. Okay.
Okay. So very commonly, most doctors will say, you don't have a uterus, you don't have to worry about uterine cancer, which is a rare event on hormone replacement therapy nowadays anyway. But my perspective is yes, because several reasons. First of all, progesterone strengthens your bones. It does have a certain cardioprotectiveness. Okay. It is protective against breast cancer, which is a very big thing. And it has a major side effect that we love. It helps you sleep. So you take it at nighttime. So, which is sleep disturbance is a major issue. So I strongly recommend my patients who've had hysterectomies, yes, take progesterone unless they don't tolerate it or they don't want to take it. It can be optional, but I try to point out the benefits.
I do have a client currently that I work with who is on, she's on replacement therapy. She's using an estrogen patch, but her doctor then gave her an IUD that secretes progestin for the progesterone component. So I'm curious about that, because that progestin does not give you the same benefits that a bioidentical progesterone would. Correct?
That's absolutely correct. And I do use an IUD for those women who really need to take progesterone. They don't tolerate it. They have adverse side effects to it. They have bleeding problems, and they have a normal intact uterus. Then an option is to take the IUD. It doesn't give you the systemic benefits, protection, but it does prevent bleeding, and it allows a woman to take estrogen without having to deal with the adverse consequences. The other possibility, which isn't used very much, is an ablation or destruction of the lining of the uterus. Simply an IUD, like a Mirena IUD, is the easy alternative.
Does progesterone, is that what causes like the bloating? Because I've heard women say, oh, I can't take progesterone. It makes me bloated. It makes me hold water. Or is it more estrogen that does that? Or is it a combination?
Yes to all. All hormones tend to retain salt, and what follows salt is water. Yes. So to what degree a woman is sensitive to one or the other or both is something we have to contend with. Now, fortunately, the weight gain, the water weight, and so forth is sensitive to a diuretic, to a water pill, which I prescribe very liberally, and it can be taken as needed, longer periods of time. There's certain types of diuretics that are not salt wasting, so you can have long-term use of the diuretic. But yeah, those are common complaints. I mean, nobody wants to put on more weight,
Right.
but
Right.
especially when you become menopausal, there's this
Mhm.
10 to 15 pound weight gain. And then, doctor, you're going to tell me I'm going to put on another few pounds because of the water weight? Are you crazy?
Right.
No, but at least, and we can prove it. You know, if somebody says to me after 2 months on hormones that I put on 15 pounds, I said, let's take a diuretic for a week and we'll see how much of it is a fluid component versus change of life component, lifestyle component, and so forth. And usually you can see the difference here.
So we've talked about the gels and the creams and the patches and orals. I do hear from a lot of women that are using pellet therapy. And one woman that I was speaking to recently, I think she's just been overdosed with her testosterone. I do want to talk about testosterone after
Mhm.
this, but
Right.
I know a lot of people will ask me, how do I feel about pellets? My opinion on pellets is I'm not a fan. Like, I did not even look into that as an option when I was thinking about doing hormone replacement. I wanted to go this route with you. And my opinion on pellets is once they dose them, when they put them in, you're stuck with them until they wear off. So if you have too much of one hormone or the other, I remember a woman who has pellets that her breasts were hurting her and she was bloated, getting cramps. Maybe she had too much estrogen in her pellet. I had another woman who I think has been overdosed on testosterone, and she's saying how she just feels, she's like, I'm really strong on the gym. I can't get lean. I just feel kind of big, puffy, bloated. And I know she's been doing a lot of testosterone pellets. So that I said, that could be an issue. I said, you really should go back to your provider, check your levels, see where you're at. So maybe you bring your tests down or to a healthy level for you so that you can start to lose weight if that's what you want to do. But what is your opinion on pellet therapy? And do you think it's going to be sticking around for a while, or do you think it's eventually just going to fade out because it's hard to really it's hard to titrate it, like you might say to me, all right, Lynn, I'm going to pull back I'm going to send you a new capsule. I'm going to drop this a little bit. Maybe it's too much, which is easy to do, but a pellet, you don't have that ability.
Right. Linda, I think as long as convenience is around, pellets will be around
Okay.
because I think that's all they really offer. Okay. With potential side effects. So you point out some good points. First of all, when a pellet goes in, it's supposed to last between 2 and 4 months.
Mhm.
It becomes, the levels of the hormone become, we call super physiologic, way, way, way above what the upper limits of hormone replacement should be. And then there's a gradual decline. And women can notice feeling absolutely great initially, and then they feel it wearing off. As you pointed out, if they have sensitivity, they're going to have side effects, and the pellets have to degrade before the symptoms go away. You don't take them out. But there's a large population of women who are very, very happy with it. I'm not. I'm a guy who monitors levels, and I see what happens. The other issue and the question I have is with estrogen pellets, is that the estrogen to give you the cardiovascular and the Alzheimer benefits usually are taken by orally. So when you take estrogen orally, it goes through the stomach. Okay, it's absorbed, goes through the liver, and then it's converted into those components that are cardioprotective. And you don't get that topically. And I look at subcutaneous estrogen as a topical. So I haven't seen any studies that have shown the cardiovascular benefits, which I think is so extremely important. That argument isn't there for testosterone, but it is there for estrogen. And the patients that I see who have been on pellets usually come off because of side effects,
Mhm.
and that's about it. But no, I'm not in favor of it. And if people, and I do have, by the way, patients who are on pellets, and I see them for other things too, like uh, thyroid, DHEA, and so forth, or maybe estrogen. They're only on testosterone pellets. So I mean, I work with them, but I don't agree with it, and I follow it and I monitor it for them as well.
Yeah, I get that question a lot too. And I'm just very curious about that. But I want to, this is a question I can never really get a great answer to, and I'm hoping that you can clear it up.
Okay.
why. So if I'm a patient and I go to my internist or I go to my OBGYN or even an endocrinologist and say, hey, doc, I want to test my hormones. I'm 55 years old, I'm feeling some certain things, and I want to see where I'm at. I read an article or I talked to my best friend who's on hormones, and I want to understand where I'm at. So I'd like to test, my estrogen, my progesterone, my testosterone. Say I just go in and say that. And women come back to me because I tell my clients to go to ask their doctor to do this. And they'll come back and say, my doctor said, lots of answers. It's not necessary. It's not necessary. We know your hormones are probably low, you're perimenopausal, menopausal, so it's really not necessary. Or I've heard, this is an answer I heard, I'm not comfortable. The doctor said, I'm not comfortable doing this. And then just sort of stop the conversation. Other doctors have just said, no, we don't, it's not necessary. We're not doing it for lots of different reasons. And I'm curious why is that? Like, why would a doctor, I mean, you go in and do a complete metabolic panel, right? Test your white cells, your red cells, look at your liver health, your kidney health, and all that blood test looks at. Why would they not just check the boxes to do those too? Is there a cost to the doctor to do that? Are they not? Someone else said to me, "Oh, the doctor's not licensed to ask for those blood tests," and I'm like, I don't understand that. So why can't a woman go to her doctor and just get her levels checked to see where she's at?
I can't speak for all doctors, obviously,
Right.
but intuitively, I would say the doctor would give those answers because he or she is not prepared to act on the information.
Okay.
And they're not prepared to act on the information either because they don't feel comfortable, they don't know that much about it, they don't want to, that's not part of their medical practice, that they don't
Okay.
want to expand, but they just do not want to act on it. All right. I think it's, if they get the opinion that you shouldn't be on hormones, I think that would be wrong. I had patients, I get that a lot. You shouldn't, you're too old for it, you don't need the hormones. That is wrong because it denies the patient an opportunity to have a quality of life that's been well supported by the medical literature. So the doctor's, bias or opinion shouldn't enter into that. But primarily to answer your question, they're not prepared to act on it. And I understand that it can be it's out of their comfort zone. Okay. They're like delivering babies, doing surgeries, whatever else they're doing. They don't want to expand, or they'll say, look, I'll give you a patch, and if you feel better, that's great. And that's it. Dismiss it. It's just like if a woman wants to talk about some sexual issue that she's having. Many doctors are not prepared to discuss that. And they'll be very uncomfortable. But you've got to find a doctor who is willing to, be open and talk about this. You don't have to see a specialist like myself. You can see a generalist who does practice and is willing to talk and offer something to a patient. And that doesn't require that much sensitivity and just a desire to help. And if you don't feel comfortable, refer. That's
Right.
easy enough.
Well,
I
that's
don't
the
do
thing.
that, but I know somebody who does, or
Right.
2 or 3 people who do. And why don't you speak to them, because they're going to be able to help you.
Absolutely. That's like, I think your point is valid. I would completely understand a doctor saying, that's not my area. I'm not versed in that. That's not my specialty, but Dr. So-and-so, I know does that. Go talk to them. Just as if you went to your GP and did an echocardiogram and they said, you know what, I don't, something doesn't sound right. I'm going to refer you to a cardiologist, or I'm going to refer you to a pulmonologist, pulmonary.
Right. Perfect.
So why, it's the same thing. Why wouldn't you just refer to a specialist? But they most times they just shut the conversation down and they don't want to discuss it. Or the other answer sometimes is, those are not FDA approved, and that is not the way. I don't support it. That's not something I want to discuss. Meaning bioidenticals are not FDA approved. So I don't know. Could you speak to that a little bit?
Yes. Bridges, how many bioidentical hormones have been withdrawn from the market versus how many FDA approved pharmaceuticals have been withdrawn from the market. I think it's a rhetorical question. You don't have to have FDA. You see, that protects the physician, right? You can always say, if it's not FDA approved, I'm not going to prescribe it. Even though doctors can prescribe medications that, if they are FDA approved, but for other purposes, for example, there's something called spironolactone, which is a well-known mild diuretic, but also has the effect of blocking the adverse effects of testosterone on the skin, right? You don't see that as a choice, but you can prescribe it. It's a cover as far as I'm concerned. And there are attempts now by the FDA to have controls over bioidentical hormones, even though they are clearly superior. Now, there are commercially made bioidentical hormones, primarily estrogen and progesterone. They work well. The problem is they have limited dosages, and I'll give you an example. Prometrium or progesterone comes as 100 milligrams or 200 milligrams dosages. But if a woman really needs 275, 300 milligrams, or 350 milligrams, it's not available to her. It has to be made. And the same thing with estrogen, and the same thing with thyroid hormone, natural thyroid versus commercially made thyroid. So these are limiting things. So I don't think you don't need FDA approval. If the doctor's comfortable prescribing that, quote, non-FDA approved, go right ahead and do it. But if they're not, they'll stay behind the, in that range, whatever the range is.
And the interesting thing too that I've learned is by talking to some compounding pharmacists is that, well, the bioidenticals have to be compounded, meaning like what you just said, they make the dose specifically for me or somebody else or Susie Lou or whomever it is. They'll make the dose. So if I need 250 progesterone and somebody else needs 175, they'll compound it for them so they have the exact dosing that they need. And in talking to some different compounding pharmacists, the compound pharmacies are under FDA regulation, or they are under FDA approval somewhat, right? So, I mean, the FDA is watching what they're doing. So it's not as if I think of, like, remember Grandpa Munster? He was always down in the basement making stuff, and he'd open the door and all the smoke would come out. Like,
right.
Like, I think sometimes people think compounding pharmacies they're like, black market backdoors doing stuff that, that's not FDA approved, but the FDA does have some regulation over compounded pharmacies, correct?
Yeah, compounding pharmacies have their own regulatory systems.
Okay.
There are different compounding pharmacies out there. We try to vet the ones that we feel are the best. Good compounding pharmacies will send out products that they make or compounds that they make to independent laboratories for quality and purity as independent. And that's why there's very limited problems with taking these hormones. Plus the fact most of the doctors who prescribe them monitor them.
Right.
It's yes.
Okay. And then, and also too, in your opinion, because I've listened to different doctors lecture about hormones therapy. Some are in favor of saliva testing hormones, saying that's the best way to see what you have bioavailable, like what you have available to utilize, versus serum, because serum changes so frequently. You could take it today and tomorrow and it could be different. Then there's like Dutch testing, which is dried urine testing. So, like, what is your opinion on some of the different ways? I know with you, working with you, because you're my doctor, we do blood work about every 60 days or so to see where we're at.
Okay. Well, as far as you're concerned, it's 60 days at this point in time because you're just starting. Eventually, when women stabilize, they've optimized their hormones, they feel great, there are no side effects, we can stretch out that monitoring period to 2 or 3 times a year. Just to make that clear. And you're right, there are many different ways of monitoring this. I think probably the most accurate way to measure hormones is 24-hour urine collections. But from a practicality standpoint, that's tough. Dutch tries to deal with that. I think saliva testing tells you what's going on in the cells, but it doesn't really, it's very hard to standardize. I would use Dutch testing if somebody presents it to me as for initial non-hormonal use, but to follow hormone levels, I don't think it works very, very well. I do use saliva testing primarily for cortisol evaluation, but that's about it. So blood testing is pretty much used by, I think, the vast majority of people who work with hormone replacement therapy for convenience, laboratory availability, turnaround time, and so forth, and cost. So, and it's fairly well standardized. So that's why we use blood testing.
Okay. And I also too, I do want to just discuss testosterone a bit, because I know a lot of doctors are very uncomfortable with putting a woman on testosterone. And I don't think there are many studies done on women and testosterone, right? The way I understand is there's a lot of literature and science based on, male and TRT use, but not as much for women. And knowing that as women, we actually have more testosterone than we do estrogen, which is always an interesting, fun little fact when I tell people that. They're like, I had no idea. But
when you're menopausal.
Yes. So exactly. So I'm curious though, because so many women, doc, are having terror. They either don't have sex at all because it's painful, or they just have no desire. They have no libido. I talked to a woman who's in her 40s a couple of weeks ago who said, I have no desire. I am not interested. She's like, I feel bad for my husband. She said, but I just, I'm not interested. And it's sad because I think a lot of women think that it's like, I'm just getting older. People don't really have sex when they're older anymore anyways, which is, I say, a big no to that. It's part of life. It's part of feeling good. It raises oxytocin levels. It helps balance cortisol. It's connecting with your partner. It's building a good relationship. There's so many benefits. So why are doctors, nervous about giving a woman testosterone? And what's your thought on it? And then what are the ways a woman can take testosterone?
Okay, so I'll answer your last question first because that's easiest. Testosterone not very very well absorbed as a pill, although we do use it in some individuals. It is highly absorbed as a cream and applied nightly, and it clearly can be absorbed as an injection, like an insulin needle injection once a week. And I have patients on all these different modes, and it works very, very, very well. As far as libido and sexuality is concerned, this is I have to deal with people's expectations. Let's assume a woman says, as you said, her libido is low. She'd like to have a better libido. I would tell her sexuality is a very complex issue. It's not only on the basis of your testosterone levels, which tends to drop from the late 20s. Okay, there's your health, your weight, your sleep, your interpersonal relationships, your stress. There's so many things involved over here, although testosterone levels do play a part. Why they're reluctant, I don't know. It requires very close monitoring because you don't want to turn a woman into somebody who's got hair falling out, acne like crazy, road rage, and so forth. It really, that's not the way to go. In fact, if anything, when we talk about optimization, this is the one hormone that I'm so inclined not to totally optimize, right? Because you have to draw a line over here. But if you work with it, so you start off at an extremely low level and over time build up, many women will find it is highly beneficial. But because of the complexity of the concept of sexuality, I tell them have realistic expectations. Some women will be chasing their partners around the bedroom, and other women will shrug and say, "Give me more." I say, "Can't because you got side effects." So it's hard to predict. What I do say about testosterone that is objectively measurable is muscle mass. Yes. And for those women who are in the gym and work out over the course of time, will have an extraordinary improvement in their strength, their durability, their lack of fatigue after working out. Right? their body composition will change, become more percentage, body weight will be more percentage of muscle mass rather than body fat. And of course, the anti-inflammatory benefits of reducing visceral fat, backing off their risk for heart disease. So the libido issue, I tell people, let's see what happens.
Yeah, it's a big one. It's a big one. And I can,
It is.
I can speak from my experience. I've never, this might be TMI, but I've never had an issue really with my libido, but I am using the testosterone cream. What I've noticed, and I've told you this, is that I've definitely noticed my strength, and I love to work out, and everybody that is watching this already knows my MO. So, but I've definitely noticed that I am feeling stronger in the gym for sure. It was one day it just sort of clicked. I was like, wow, that stuff's really starting to work, because I felt much, I felt stronger in my lifts, and I love it. And the other thing I've noticed too from the testosterone is that any joint achiness or stiffness that I was having has really pretty much almost gone. Like getting out of bed every morning is like Christmas morning, doc. Seriously, I get out of bed and I'm like, I feel good. And before I met you and was on this therapy, I would sort of get myself up, and that's not like me. But for the last 2.5 years or so, I was definitely feeling like waking up fatigued and a little stiff, a little achy, until I started to get moving and the juices started flowing, and then I would be okay. But I'm not experiencing that effect anymore.
That's the anti-inflammatory benefits of testosterone. And I do deal a lot with anti-inflammatory medications, low dose naltrexone and other things, but I'll even HGH. And I'll say, look, let's just see what testosterone does for you first. And I'll tell you about the vast majority of people will benefit from that alone.
Yes, it's so, I mean, it's been my experience. So, I'm really, really happy. I'm a huge advocate of doing bioidenticals. And I know you do work with men, and I want to just touch on that a bit before we end, because all the women that I work with that eventually go on hormone replacement, they all have husbands, and it's, there's some of the guys aren't doing that great either, doc. A lot of them, they have a lot of visceral fat, they don't work out, they're sedentary, they're sitting at a desk all day, or they're sitting on the train, and then they come home and they sit on the sofa and they're not working out. So if you get a guy that comes to you that's maybe got to lose some weight and is a little more sedentary, or just feels like his get up and go is gone, or maybe his libido is not so great either, like how do you work with men in that respect?
Well, I'll just tell you a little anecdotal story. As a gynecologist, I started off doing this with 100% women. And then after they showed major improvements, the husbands or boyfriends would come to me saying, I want what she's got, because they see the difference. And I reluctantly started working with men, but not anymore. So I have a large component of the practice is with men. And the approach, the optimization approach is the exact same with them as it is with women. Obviously, the hormones are different, the dosages are different, and so forth. But we usually get some really very excellent results. Now, we're not looking for people who are going to be putting on multiple masses of muscle and be, competitive challenges in the gyms and so forth. But people are very happy, and the duration of stay, people who stay in the program, is around 90% for men and for women. So it works out well. And I do see major changes in men, no question about it. It's usually, and the ones you see it most in, the person who's like late 30s, early 40s, overworked, may not be a couch potato, wants to do better in the gym, but is so overwhelmed with stresses of work and can't perform at home, and maybe some erectile issues in young men, which I'm amazed about. I thought that was an older man problem, but it's not, and can be highly beneficial.
Okay. And then if someone is watching this and they're like, hey, I want to get in touch with Dr. Jacobson because I want to explore this, what's the best way to get in touch with you?
Well, the phone number is 203-869-8353 in Connecticut. There's a website with a lot of detailed information called greenwichhormones.com. And I can only work in states that I'm licensed in, but fortunately I'm licensed in about 7 states. most of the New England states, California, Florida. But
Okay.
outside that area, unfortunately, the waiver that was given to doctors because of COVID to work in all other states has been rescinded.
Okay.
So not able to help people in other states like that.
But could someone, if someone's in a state that you're not licensed in, could they fly into Connecticut and see you and be treated by you, or no?
No,
Okay.
no. First, it's a telemedicine practice. Okay, so everything is done on virtual meetings and so forth. So there's nothing to be seen, but it's got to be the state that the patient is residence in.
Okay, so you could also maybe you can refer them to someone in their state if you know.
Sure, and I do. And if somebody is part-time in just say in Florida and part-time in Idaho, I can see that patient because she has a Florida residence, for example. You know, so there are ways of dealing with this. But for the most part, it has to be in states that I am licensed in. And that's stated on the website.
Okay, awesome. All right, Dr. Jacobson, thank you so much. This was a fabulous hour. We have really great information. I know a lot of people are going to get a lot from this. So
great. And Linda, thank you very much for being able to give this to your patients, and that they're aware of what's going on in the world, and they know they have options, they have choices, and if they can't get them from the doctors, they're not comfortable, get referred. Just
absolutely.
get referred to somebody.
I always tell them, I'm like, get the knowledge. Knowledge is power. You don't have to do anything if you choose not to, but at least have the info to make an educated decision from. So
excellent. Thank you. Thank you so much.
Thanks, Dr. Jacobson. Have a good day.
My pleasure. You too.
Bye.
Bye-bye now.